quickly, I want to do a short recap on anti-tubercular drugs here. So what we have, antiviral drugs are drugs used to treat tuberculosis and to some extent in treatment of leprosy. So looking at tuberculosis for now, we're looking at some of the symptoms you might find. You find that the patient, they tend to cough a lot at night, right? They produce a lot, they sweat a lot, there's fever, then they produce some sputum. So the goal of therapy is that if and when you start treatment outcome, the cough should decrease, sweating at night should decrease, fever should also decrease, sputum production should decrease. Then this, by the time you analyze the sputum, ALB levels in the sputum should also decrease. This is just for the drugs, right? Now we said about tuberculosis is a serious infection. It is communicable, it's infectious, it is chronic, and it tends to have periods when it will come out so big. There are times that it also relapses, not like it is in remission. Other times it is very, very open. So we're looking at the drugs we use. These are the first line drugs. These are second line drugs. Because of the development of resistance, which happens a lot with tuberculosis, you don't get to give a singular drug. You have to give a combination of drugs. And this is the first line drugs here are the drugs that are combined together. We have rifampin, Isoniazid, we have pyrazinamide, we have ethambutol, then we have streptomycin. Take note, streptomycin is an antibacterial agent. It belongs to what? Aminoglycoside. These are second line drugs. Kanamycin here is also an aminoglycoside. The other drugs are this PAS, para-aminosalicylic acid, ethiniomide, cycloserine, capromycin. But these are the primary drugs that are used, the first line drugs. So I said that to ensure the drug work, the drug must be able to target something in the microbacterium and not in the host cell. So host cell, mammalian cell, have a lot of our cell has a cell membrane that's made up of cholesterol. Call it a phospholipid bilayer. Our cell membrane has a phospholipid layer, then an aqua layer in the middle. Phospholipid up is like, is it a burger now? Burger, you have is it that part that's made of flour here? The other part, you have a sandwich. Yeah. Then you have all of those things in the middle. So a normal cell membrane for mammals is like that. We have phospholipid bilayer, phospholipid layer, that is phospholipid bilayer. Then the central part is usually an hydrophilic layer. So the two layers here are hydrophobic. The central layer is hydrophobic. For mammalian cell, we have a lot of cholesterol there, which is a phospholipid bilayer. So if you want to target a mammalian cell, we have to make drugs that will target cholesterol or phospholipid in our own, because our cells are majorly, the cell membrane are made of what? Phospholipid. Do you understand? But so since we are trying to target other organisms that infect a human cell, fungi cell has chitin in the cell wall and has a lot of ergosterol in their cell membrane. So this ergosterol here, ours is what? Cholesterol. So it's easier to target chitin production or ergosterol production in fungi, because we find this in fungi and not in human cell or mammalian cell. For bacteria, they have a lot of peptidoglycan there. So it's easier to target peptidoglycan biosynthesis because it is just peculiar to bacteria in our bodies and not the mammalian cell, right? For viruses, they are ugly. Some of them have RNA, some of them have DNA. So that is a bit complex, but they are still, because they have to make their own proteins and DNA. So you can still target that process in them. For tuberculosis, we say that tuberculosis, their cell wall has mycolic acid, a lot of mycolic acid. So without mycolic acid, you cannot make a cell wall for these organisms. Mycobacterium tuberculosis, right? Or the other one, Mycobacterium leprae. So they have mycolic acid there. So this can now become a target for drugs. This becomes that is purely what we do. We look for what is present in the organism that is absent in the host. So the major target is what? Mycolic acid. It is understood. So that's why I put cell wall synthesis. So I said, because for most mammals or human beings, we are heterotrophs. We eat food. We hardly produce we don't biosynthesize our food. We have to go and look for our food and eat it. most of these organisms, because they cannot go to the market, they cannot go to the kitchen, they actually have the capacity to produce their own food at the spot. Plants have to use sunlight and water to produce glucose. I can't stand in the sun and drink water and produce glucose. We die from what? We die from it, or from what do you call it, an heat stroke. Right? So that's why we have to go and eat food. Animals of predators cannot get carbohydrate from just eating leaves. They have to go and eat feed on another animal. So this organism, because of their nature, which they are autotrophs in a way, they tend to produce the basic necessities of their life. So they have a cell wall. If they don't have a cell wall, they will have what? A cell membrane. So you can target cell wall or cell membrane. And I said any organism, any drug that can damage the cell wall or cell membrane is usually static, either bacteriostatic, fungistatic, or tuberculostatic in here. Because when you damage the cell wall, what you damage is that it's like you stab a human being and everything begins to leak out. So a person cannot have everything leaking out and still be alive. They tend to die. So usually any drug that is a cell wall sense inhibitor or cell membrane disruptor is usually bacteriostatic. That is usually a rule of thumb. But I also said that what most of the drugs we use, either for antibacterial or so, they can be both bacteriostatic and bactericidal. But cell wall synthesis inhibitors are usually bacteriostatic. Anyway, protein synthesis inhibitors are usually bacteriostatic. Cell walls are usually bactericidal. For bacteria, aminoglycoside is an exception for protein synthesis. Protein synthesis inhibitors are usually bacteriostatic, but aminoglycoside, also a protein synthesis inhibitor, are bactericidal. Do you get it now? So if you inhibit photosynthesis, the organism does not have to die, you just have to adapt. DNA, this usually for viruses, but we'll get there. So having said a bit about this, we now want to begin to look at some of these drugs, and the first one I want to look at there is isoniazid. So what I said was that for most of the antitubercular drugs, we said that you should give the drugs on an empty stomach. Usually we say that what you should give, people should have eaten before they take their drugs, but drugs here are given on empty stomach. So if you have given a drug on empty stomach, you should expect GIT irritation, nausea, vomiting, diarrhea, or anything you have to do. So that should be expected from the drugs you gave. Then we said that because tuberculosis is a chronic condition, you must tell your parent at least you are going to use the drug for at least 6 months. Some take it for up to 18 months. And you also have to tell them that, because you have a disappearance of symptom, it does not mean that the person is already cured. That you need to take the drug for as long as you have been told to take the drug, whether or not you have symptoms or not. Right? So coming back to this, I now started talking about isoniazid, that this drug, what is the MOA? It inhibits the biosynthesis of mycolic acid, which is a component of the cell wall of this mycobacteria. Tuberculosis. So once you inhibit it, what happens? You destroy the integrity of the cell, meaning that the cell is no longer stable. So content of the cell can leak out, and content outside can also move into the cell. So for these cells, before they can be dividing or they can be resting. As I said that the organism, a person may have tuberculosis and not test positive for it, really, because or may not show the serious symptoms because they may be resting. So the drugs we are going to give should be able to target both of these phases, the rapid dividing phase and the resting phase. So if you give isoniazid that target inhibition of synthesis of the mycolic acid, it is cider, like mycobacteria, it is tuberculostacidal for rapidly dividing cell, and at the same time it is tuberculostatic for resting cells. Do you understand? So that means this drug can be both cidal and static depending on the phase the organisms are. Do you understand? So what is the indication generally? General of what? Tuberculosis here. That's the indication. Communication. Once the patient develops hypersensitivity, you may need to withdraw the drug. If the person already has liver issues, issues are present, liver problems already, or during the use of the drug, the person develop hepatitis and all of those things, you may need to withdraw the drug. These are the basic qualifications you have to look out for. unwanted effect to be what? Hepatotoxicity. This drug can destroy part of the liver, right? We also produce this peripheral neuropathy. So the neurons are affected. So to reduce the severity of this, we ask that patients are on supplement of what? Vitamin B6, B vitamins. They supplement B6, pyridoxine, to ensure this. Then in some cases, some patients have what we call hemolytic anemia. These are the major unwanted effects that we get. So, and I said this does not in any way exclude the GIT symptoms. GIT symptoms can be because one, the root of this drug is oral route, and you are going to give the drug on an empty stomach. So GIT symptoms would be present. Do you understand? So moving on to now once we ascertain that what the root is what? Oral. Yeah. Thank you. Once we ascertain that the root is oral, we now want to look at some of the things like what are the pharmacokinetic profile of this drug. Once you make pharmacokinetics, we're talking about absorption, distribution, metabolism, and excretion, elimination. So for a drug that was given via the oral route, you need absorption. Two things will happen. Is the drug well absorbed or poorly absorbed? This drug is well absorbed via the GIT mucosa. Distribution, it is widely distributed. So is there a drug is widely distributed or distribution is limited to probably plasma protein and GS. So this drug is widely distributed. Metabolism, this drug is majorly metabolized by the liver. So if it happens that way, that means this drug will go through the phase 1 and phase 2 reaction. So usually this drug requires acetylation. This drug requires acetylation. So what's acetylation? So usually acetylation is a phase 2 reaction under metabolism. Acetylation is a phase 2 reaction. So for this, individuals can either be a fast acetylator or a slow acetylator. So for fast acetylator, those that tend to process this drug faster, the half-life of the drug in their body will be 70 minutes. Those that are termed slow acetylators, the half-life of the drug will be 2 to 5 hours. So once you talk about acetylation, usually for any drug, once you talk about acetylation, some people are fast acetylators, some are slow. So for that case, you need to know where the person belongs to, because that will determine the half-life of that drug and how you can dose that drug. How you can dose. But for this, it may not be a problem because what you are dosing it here once daily. Do you understand? So because you're doing it one day, so it's more or less you now begin to work out how long the level of the drug in the body. So how we talk about this? So if it's metabolized in the liver, most likely to be excreted in urine or secreted in the bile. If it's not in the liver, it may not be excreted ultimately in feces. But majorly, it will happen through either of these routes, right? So we look at drug interactions. I mentioned warfarin, phenytoin, diazepam. The levels of this can affect isoniazid and vice versa. Now this is the dose. The dose we give is this is aluminum hydroxide. Usually, this is a component of maybe your antacid. Find a lot in antacid, and this is diazepam here for different purposes. So the dose here is 5 mg per kg per day. This is what the ADR. That for an adult, you work out the dose based on the person's weight. So if once the person is more than 60 kg, you just give 300 mg once daily. And like I said, this is just one of the drugs you will give for the treatment of what? Tuberculosis. You can give the drug once daily, 300 mg once daily, and it is POV what? Through the mouth. So then some of the issues that can come is that for people on this drug, they may experience there might be food. At times we talk about drug interaction, drug-food interaction. Now, elevated thiamine levels might cause hypertension and other features there. Hypertension, maybe other features. So this can be due to food like chocolate. Chocolate is a big problem here. Then which other food is seriously? But chocolate is what most persons tend to have to do a lot with. Thiamine levels. But at some point, I'm still going to talk about this because of thiamine itself. Then elevated histamine. So fishes like tuna are so rich in I mentioned yogurt, fermented foods. Fermented foods are rich in thiamine. Fermented foods are so rich in thiamine, so persons have to be careful. So histamine is also, you have to be careful with histamine too. You have to be careful with histamine, probably from food like tuna fish, probably yeast itself. So once these are done, the person is good. So while I was discussing metabolism, I discussed that some drugs may be concentration dependent or time dependent killing the exact effect that. So if a drug exerts effect via the concentration dependent method, now that drug needs a high dose for a short period to exert its effect. For a drug that requires time dependent killing or the effect, the drug needs to be above a particular level of efficacy for a long time. For a long time. Do you understand? So the drug needs to, so for this type of drug now, you can give it as continuous infusion. Or you can give like maybe 4 times a day. Time dependent killing. You could give like continuous. So if you say that it's given like that, you only find amigdaloside given as continuous infusion. Because what you want to give the drug and achieve a very high dose, and then allow the dose to taper off. So for those drugs, you need a high dose. So if a person has a liver issue and you have this, and you have to dose the drug often, you still may need to give the very high dose, but reduce the frequency of dosing it, because once the dose is too low, the drug loses efficacy. Do you understand? So if it's time dependent, you can give a smaller quantity of that drug repeatedly to achieve the same purpose. So I think with this said, I think this is where we start with Isoniazid. That Isoniazid is a drug we give in the treatment of tuberculosis. One of the drugs we give in the treatment, because you cannot give one drug, because if you use one drug, usually resistance would develop, and that's not what we want to do. So thank you very much for listening. Yeah.